So we're forever trying to create a better mousetrap, and there are many ways of improving antibodies, and many have been tried, and some have been successful. Obinutuzumab has been engineered to have more ADCC. Unfortunately, it loses some complement anti-tumor effect along the way, but it's now approved for the treatment of low-grade lymphoma, as well as for chronic lymphocytic leukemia. What are your thoughts on that? I mean, there's some recent studies using it.
I think in CLL, the large pivotal trial, I look at chlorambucil versus chlorambucil plus rituximab or chlorambucil plus obinutuzumab. The data was very impressive in PFS. One has to remember, though, this is a much higher dose of a monoclonal antibody. The dose that we use at 375 milligrams per meter square was somewhat arbitrary, right, and the schedule. So here this is a more intense schedule, but clearly there is some preclinical data and some clinical data to some degree now that suggests that this is a better antibody. And is, as you said, is being tested across the board in B-cell lymphomas, follicular and large cell lymphoma.
So do you think that this concept, of that there's less fucosylation and therefore it may be activating NK cells? I think this is something that certainly is supposedly true for obinutuzumab, as well as I think that there are other antibodies in development that have that hypofucosylated mechanism of action. Do you think that that's something that makes sense to you? That's right, glycoengineered antibodies.
It gives a better
and there are other approaches to
It seems like it's got, I mean, a lot of things that we think about it with antibodies, and for many years trying to understand what the mechanism of action in vivo versus in vitro consumed decades of research, but I was frankly skeptical of how much of an improvement obinutuzumab was over rituximab. I mean, clearly in CLL, we're using a bad backbone of chemotherapy with chlorambucil. It was sort of no-brainer that was going to happen. But the results are impressive in MRD and in CLL. But the recent the recent studies that show, even in the frontline setting, there was a press release just a few weeks ago of the frontline use of obinutuzumab in combination with chemotherapy versus chemotherapy in combination with rituximab, and it's met its primary endpoint. So I think that's really where the proof is going to be. We wait for the full presentation of those results. Hopefully we'll see them this year at ASH, maybe.
It's a really important question. We'd like to understand. We alluded to the fact the microenvironment, the immunological signature and all that. We really don't have a good handle on what makes a patient with follicular lymphoma, where we use it as a single agent, except DFC polymorphism, right? So there's a polymorphism of the DFC receptor that can make the antibody a bit stickier, right, if we want to call it simply, and therefore a better ADCC. So there's three different VV versus FF or FV, and then that gives VV have a higher CR rate and a higher duration of response. This has not been proven in the context of our chemotherapy, but the whole understanding of what's the T cells involved and what's the degree of, what's the activity of NK cells in those patients at the time they received immunotherapy, to my knowledge, has not been really documented. There were some attempts at the beginning when I was at MD where we combined with cytokine, and then GM-CSF, IL-12, you name it, and then there hasn't been really a huge benefit. The only real benefit that was seen was when we started combining with lenalidomide. And lenalidomide and rituximab in follicular lymphoma, talk about NK cells, right? Increased NK activity and CD8 positive T cells. The results from the phase 2 at MD Anderson was very, very impressive, including molecular CR. So based on that, there's a large relevance trial that we just closed with 1,000 patients, and we're waiting for the results. But I think this is going to be something that is going to be important because it might help change the landscape in follicular lymphoma.
And what about targets? CD19 versus CD20 versus CD22 versus even CD40. Do you want to comment on?
The rationale for CD20 was there was not a rationale except that it was a stable molecule, and it appeared that it was not internalizing and it was easier. There's some discussion that CD20 might, we know that some antibodies type 1 can cap the antibody. There's some question that it can internalize or shed. I don't think this is really sorted out in the clinical consequences, but there are some other antibodies that are targeting CD19, CD30, and these antibodies not really as naked antibody, more as antibody drug conjugate. And then it's interesting to know that there's 5 anti-CD30 naked antibody that were tried in B-cell in lymphomas, basically, and with basically no activity. And once we moved into the antibody-drug conjugate, that's the story of brentuximab. And we can also use in large cell lymphoma, that's or T-cell lymphoma, when they're CD30 positive or anaplastic lymphoma.